Welcome to Podiatry Practice Mastery, where we're trying to get you to the $1 million mark and beyond in your personal production, in your podiatry clinic. I want to talk today about how a recent patient found me. I had two patients today that came in because they found me with my YouTube videos, and I had one patient that Googled my name, and what she said was funny. She said, she put in like a podiatrist with the best or the most reviews, and when she did that, my name came up probably because I was in her vicinity. So one thing I want to share, kind of our little secret for getting online reviews. So our practice has about 1,000 or a little over 1,000, and everyone else has maybe a couple hundred reviews. So the first thing I'm going to share about that, and then the second thing I'm going to share my little algorithm for doing YouTube videos and yeah. So first thing, how we get reviews. We've tried a couple of things, but what works best for us is we have an automated system that we used to use called Swell. And so Swell, after every patient comes in, it integrates with your medical record and it sends them a review request about 5 or 6 in the evening, and they give a review. It's a really easy one-step process. Hey, did you have a good visit? And then would you give us a review? That's pretty much it. The newer system we have right now is a little more cumbersome with ModMed. It is with Clara, and it asks, first it sends something that says you have a message, so you have to put in your date of birth and things like that, which makes it, that's one difficult step. Then when you read the message, it says, did you have a good experience? And depending if you say yes or no, either one, it'll ask for a review. So I think that two-step adds a little bit more of complexity into the system, and that's why I don't think it's working as well. So we are considering switching back to Swell, because the current one, even though it's less expensive, who cares how expensive it is if it doesn't work as well. So that's the first thing. The second thing is how does content work for me? So I am not a influencer on YouTube by any means, but I like to create content to make my life easier, and I'd like to make the best use of my time in terms of efficiency. So the YouTube videos that have the most traction, I know this is obvious, are the oldest ones. Okay, so the oldest ones, the longer they've been up there, the more traction they pull and the more revenue they bring in. I used to do kind of ugly ingrown toenail videos. I got a little bored after doing like 15 or 20 of those. So they do produce some revenue, but I don't really enjoy doing them. The full length version videos, which are basically recordings of my patient presentations. So if you're not familiar with what a patient presentation is, you can go to patientpresentations.com. You can kind of learn about how I make patient presentations. So basically they're PowerPoints, and I would share these PowerPoints on a screen with my little head talking. Those are the ones that have the most traction because they're really, really comprehensive, and it explains exactly how I treat those conditions. So those are the ones that have the most traction. What do I do today? Well, today basically the issue is I don't have like a schedule for recording these longer videos. So I do YouTube Shorts, and I do that in between or during patient visits. So I have a cell phone on me. I have two phones. So one phone is with my scribe that's listening to me, and the other one I use something called SubMagic, SubMagic, and that automatically puts subtitles, but not by me. So what I do is on there you can upload a video or record a video. I record a video on the device, it automatically uploads it to the cloud, and then my virtual assistant goes in there and puts subtitles and and it automatically gets some really good type of titles and descriptions and things like that. And then they post one per day. And this is how many patients are coming in now for my YouTube videos, because I'm consistently posting YouTube Shorts once a day. I think patients, their attention span is lower, and then we can reutilize those videos then for the best videos for your ads, for like your Google ads, your Facebook ads. You can reutilize them by putting a call to action at the end. So that is not my idea. I did steal it from Alex Hermosi. So it's a good idea, and that's kind of what's working right now, and that's how I make videos in the office. I don't want to always just go over the good things. I want to go over some bad things today with the office. So the bad thing is I came back from a little like 12 days of vacation, And one of the challenges with ModMed is the paperwork. So the signing of paperwork and faxes is kind of a pain. It's laborious. There's not really a lot of efficiency in it, and you have to kind of like use which one of those pens, right? You can it only works on the iPad, so you have to have a separate iPad because I don't do all my work on iPads. Separate iPad. I log in and it always logs me out. Because otherwise I do everything else on the desktop, but you can't sign documents on the desktop. So I have to sign them in, and some documents I have to sign, other documents I have to review and send to my staff. So it's just a cumbersome process. It's not the best feature, in my opinion, in ModMed. I always like to be clear of like what are the good and the bad. And so what I ended up doing today is the ones that were kind of a pain, I just printed out. I printed out, gave to my staff, and had them sign. I know some other doctors, they have them print everything because the amount of time and frustration that it took me was not worth it. Same thing with refill requests. Refill requests for like medication sometimes can be a pain because they're sending me these ones to actually fill out. So I usually just delete those and I put in a new prescription for the patient. So that is something that's a challenge. Another challenge today was a patient asked for a refund for 6 sessions of shockwave. And I don't usually have this that much. I called them. I didn't get a chance to talk to them. But their thought was, they saw 3 other specialists for their sesamoid pain, and I don't know if it got better. That's what I want to ask them. And they said, well, you shouldn't use shockwave, or shockwave doesn't work on sesamoiditis. Now, I find it does work on sesamoiditis. Maybe in her case it didn't. And I'd like to know what you guys would do. I may, just because I don't like headaches, I may just refund it. I may refund a part of it. I may not refund anything, really. I just want to see if she got better and kind of see what was going on. And I'd like to see who said that shockwave doesn't work for sesamoiditis. That's what I'd like to know. Most likely would be someone that does not do shockwave therapy. That's another bad thing for the day. Another bad thing, a patient came in and asked for a refund of her orthotics. So she had shockwave for her foot pain, for her Achilles pain. She is totally better, but she still has pain now to her. Actually, she doesn't have pain. She just can't wear her orthotics. And so what I did with her is I actually sent them back to the lab to have them redo, because I think the arch was just in the wrong spot for this patient. And this is something I may refund her. So I tend to refund if they ask, minus the lab fee for orthotics. I don't have a ton of refunds, maybe 1 or 2 a year. So really, I'm okay with refunding it because she got better and she also did 6 sessions of shockwave. That was another kind of a negative thing. The last negative thing was I had a lot of, my first day back, I had many routine patients. And I'm like, what the heck is going on with all these routine patients? I didn't understand why, because it's not my routine day. We ended up looking into it, and we have a new virtual assistant making appointments for us. So they are just answering questions and then just fitting them in. But I guess they didn't know, or they didn't get the memo, or they forgot, for routine appointments, they're not supposed to do them otherwise at any time except Friday morning. So this was kind of a challenge, frustrating thing, but I didn't know the answer to that, and so I asked my staff to look it up, and they said, oh, it was the virtual podiatry assistant, and they put them in the wrong place. Okay, so that was the kind of the good, the bad, and the ugly for the day. Okay, in terms of patients, once again, because of the routine, it didn't make the day too great, so let me go into this. So first patient was a LVP, least valuable patient, was a routine patient. Next patient was a 52-year-old man with cantharidin. I did a wart. Now, this was a couple of things I wanted to talk about, are add-ons for office visits. So when you change the course of treatment, you can add an office visit. So this one, since I added imiquimod, he had done 4 sessions of cantharidin, was not seeing much progress. We added imiquimod to that. I think that condones for an office visit. But I also talked to him once again about Swift. So I think in his case, he already did 4 treatments, like once every 3 or 4 weeks. And so he may have been better off if he did Swift, because it may be gone by now. So I did remind him of that, but he wasn't ready to go to that yet. Next was a 76-year-old male who had, this was a newer patient. So we did a diabetic foot exam and we did nail care for him. So this wasn't because of the podiatry assistant scheduling. Next was a patient with a 64-year-old female with bilateral IPJ hallux ulcers. Debrided those, going to see her back in about 6 weeks. These are chronic ulcers that just really almost never heal. I think she really needs some work on the first MPJ to help the bunion / hallux limitus in that area that she has. Next was a 40-year-old man with a follow-up for peroneal tendinitis. This is a good patient. He's a young man. He was in a cam boot, took some meloxicam foam rolling, and he's 100% better. So not so much a LVP. I call LVPs basically level 2 visits, which very rare. So he was like just a follow-up. Next was a 79-year-old female, had a porokeratoma or IPK on the 3rd digit, hammer toe treated with a crest pad and new peroneal tendon pain. So she did. I gave her a physical therapy prescription, so she had the office visit, that lesion destruction for that, and I'll be seeing her back in after the PT if her foot pain doesn't go away. Next was a 31-year-old for an orthotic follow-up. She's doing much better. She had some Achilles tendinitis that's feeling better for her. She is a PA. And so I think she might need a little bit more shockwave, but she can't afford it right now. She may do that in the future. The next patient was a 5th toe. She has pain on the lateral 5th digit, and we ended up doing actually the medial 5th digit, and we ended up doing a matrixectomy on the 5th toe. I don't do many 5th toe matrixes, but I originally thought it was due to her tighter shoes. She said she's tried wider shoes. I somewhat wonder, because there's very few reasons we do these, but we did a matrix for her. I'm going to see her back in 3 weeks. Next was a nail care patient. Next was an 85-year-old female. This is the one I've been seeing. She's on 6 of 6 of shockwave for the really big midfoot arthritis. Now, last visit, I did a sinus tarsi injection, and it made most of her foot pain go away. So I wonder if the midfoot pain really isn't the culprit, and it's more the sinus tarsi or the subtalar joint pain. And I don't mind doing cortisone in a different place and not doing shockwave. I think that's fine. But then again, she's not a good surgical candidate. She's got this huge dorsal spur on the midfoot that I thought it was like bone marrow edema from that. But really, if the cortisone helped her, she's 80 some, so I just see her back as needed for cortisone. Next was a fungus follow-up where I did a booster dose. So those are always easy follow-ups. Next was a 42-year-old female for an orthotic. This was that redo that I had to do. Next was a 64-year-old female for right Achilles follow-up. She wasn't really able to do anything that I recommended, and these ones are kind of frustrating. So what I tend to do now is, since she didn't do what I recommended, I told her again to do it. I gave her meloxicam. I gave her foam rolling. She already has a night splint. Talked about the morning stretch, talked about shoes, the UFOs, which she didn't get. And I said, well, why don't you just give me a call if you want either physical therapy or if you want to do shockwave. Though I think really shockwave would be the best thing for her. But I find patients that don't want to do anything, I tend not to see them back. I tend not to make follow-ups for them because they're not really wanting what I think would help them to get better. So this one I just kind of left it open-ended for her. Versus seeing them back at a certain time and then kind of trying to talk them or educate them into doing what would help them get better. Next was a 55-year-old man. He had bilateral tinea bilateral fungus, so he did the fungus kit and LFTs, and he also had a mild Haglund's on the right, which wasn't painful for him. And I'm going to see him back in 3 months after that. Next was a 78-year-old man with an ulcer of the IPJ hallux, kind of a fissure that he has going on there due to a previous first MPJ fusion. So he has a fissure at the distal tip because of the way it was fused, and it's just not healing. He's been using collagen, using a lot of things I recommended, like a carbon fiber inlay. I recommended a rocker bottom shoe. I've recommended an ortho wedge shoe. And I recommended him go to the wound center. But this guy didn't want to go to the wound center. There was another ulcer as well of another patient with an IPJ, and he did go to the wound center. I try to send as many wounds just because I don't do a lot of wounds, if you're listening to this anytime, you realize. And so I try to have them go to the wound center. I just think they'll get better faster there. And so that one I sent to the wound center. I did add an office visit, even though I've been writing the ulcer for a while, because I think it's appropriate considering that. Because of the medical decision making. The next patient was a 76-year-old for right hallux limitus, recommended the carbon fiber insert, anatomic shoe, and possible fusion. And then the next was a 65-year-old man with that ulcer, another ulcer. Next was a 75-year-old female for a fracture follow-up. For the hallux, it's much better. Got x-rays. That's the least valuable patient because all I got was the x-ray. I did not even do an office visit because it was a fracture follow-up. Next was a 55-year-old for left Achilles, so this is number 2 out of 6. And then next was a 50-year-old man with left hallux limitus. Only had pain when he was like kind of down on, like kind of doing like a forward lunge and putting his weight on there. But I explained it was more for functional hallux limitus, so I talked to him about that. So that was the day. Once again, if you guys have any other thoughts, shoot me an email. I always like to hear from people, kind of what's working for your practice. I'll be happy to share it here, any other things that are working. Okay? Don at podiatrypracticemastery.com. Okay, guys. Thanks.